No está todavía, ¿no? Abierto.
Cuando queráis.
Vale, pues podemos empezar.
¿Un correo electrónico o...?
Adelante, cuando queráis.
Vale, pues Susana, te he mandado un correo, un mensaje. Yo creo que si ves que tardan los ponentes, a lo mejor se les puede hacer una pequeña llamada. Sí, os dejamos un poquito de tiempo. Vamos a empezar. Hi, we are starting the conference now, okay? Venga, empezamos. Alex, ¿le has dado a comenzar?
Sí. Le di. Adelante.
Vale. Muy bien, pues bienvenidos.
Welcome. Welcome. We, in the panel on population with chronic pathologies, this is a bilingual panel session, so please remember, if you want to listen to the translation, you have to go down to the menu bar to the icon of the world. You can select either English or Spanish. All the presentations will be translated into the other language. So please do select the language that's best for you. First of all, thank you. Thank you very much to all our viewers and listeners, and thank you very much to the speakers of this panel. Thank you because, well, it's been very kind of you to share your research with us, and it's great that you're here sharing this afternoon with us all. I will be introducing each one of the speakers. They will also give us a very brief introduction, telling us where they come from, what they're working on, and they will proceed to share their work with you. We're going to start right now. So, Sandra. Yes, can you see my screen? Please go ahead, yes.
Hola, buenas tardes.
Hello, good afternoon. My name is Sandra Avellaneda. I am a nurse in the Clínico of Valladolid, and I come here to talk about assessment of the implementation process of the Good Practices Guideline, also on care and handling of ostomy. First of all, I'd like to thank the scientific and organizing committees for having allowed us to present this research work in this forum. Authors of the work declare there is no conflict of interest that has to do with this work. So what is an ostomy? An ostomy, as we know, is an opening that has been surgically created in the abdominal wall that goes out and makes the feces and urine go out. It can be permanent or temporary, and the most common are colostomy, ileostomy, and urostomy. And the most frequent, as we know, is colostomy, with 55.1% of patients that are ostomized. In Spain, the estimation is, because we don't have official records, we calculate 70,000 ostomized persons, and every year 16 new ostomized persons. If we take into account that 70% of these ostomized persons are going to be having some kind of complication or side effect, well, then both their care and follow-up are very, very important indeed. And what are the main complications and side effects? Well, those belonging to surgery and those to the stoma. Within the stoma side effects, we have the early ones that happen in the first 30 days after the surgical intervention: bleeding, hematoma, necrosis, ulcers, skin irritation, and those that come later, that is after 30 days, and that's prolapse, hernia, and then also stenosis. But a good part of this physical complications, but also physiological and also psychological side effects that have to be taken into account, and they make daily life more difficult. They see an affectation of their bodily image, and this affects their self-esteem. There's also a loss of sphincter control, which makes it difficult both to have good social and work relationships. And we see changes and habits occurring in their daily life behavior. And this can ensue in a reduction in the quality of life of these patients. Hernia, NEO, in this Ontario, the Ontario group has created a series of good practices based on scientific evidence, and these are developed systematically because they're based on systematic reviews, and they lead to optimum health results, and they foster consistency and good organization in care. In our hospital, we are implementing and deploying this. We have Medina del Campo Hospital, that is a center for excellence in care, that is monitoring our deployment of the guidelines. One is care and handling of ostomy of the 2009 version. Currently, there's a reviewed version translated of 2019 that is support to adults that have to live with ostomy. In the previous period to implantation, special training was carried out, and we looked for persons that would promote this and that would work on these recommendations so that we could adapt them and work on them in order to make sure that we could implement them in the hospital. These recommendations are the ones you have on the slide to carry out a full assessment of the patient and the family, pre-op information both to the patient and the patient's family, to set the stoma's location, and then to assess before the surgical operation, and then later on according to the device. So we think of the implementation of our goal. It means to deploy this good practices guideline on care and handling of ostomy in those units in which we are working on the deployment. What method have we used? Well, a special descriptive study that's retrospective. Our sample was composed of patients that had been discharged with a new ostomy in the units of general surgery, urology, and the nursing stomotherapist's nursing office. We compared two periods, second quarter of 2019, when the guidelines had not been deployed and when the special stoma-therapist nurse office had begun, and then first quarter 2020, when the recommendations were being deployed and when there was a full consolidation of the nurse's office. So data. CARVID is a special database we created for these centers that work for excellency in care, and they use the clinical record of patients anonymously because all this is worked on so that anonymity is guaranteed. What are the variables we selected? Well, those that fit in with indicators of guidelines for good practices, and they typically very much related to the recommendations that we are implementing currently at the hospital. Pre-surgical assessment and teaching, pre-surgical education, then the marking of the stoma, post-surgery education and assessment, programming follow-up, and then also the acquisition of skills as regards care of stoma, that is, well, measuring, cleaning, and changing the bag, and this either the patient can do or the carer. These are the results obtained. On the one hand, we can observe that both in the first quarter and the second quarter part of the study, there are many men more than women. Average age in the second quarter, 72.85 plus less 6.16, compared to 76.78 plus less 6.95 in that first quarter. So there's not a major difference, only maybe more age in the first quarter of 2020. We analyzed the types of stomas that were removed and that were performed, and we see that the most frequent is colostomy. In urostomy, there are not marked differences, and funnily enough, in the second quarter of 2019, no ileostomy was performed. We have also analyzed the kind of surgical intervention, whether it was scheduled or practiced as an emergency procedure. In the first quarter 2020, we see a slight reduction in the urgent or emergency surgical operations. And finally, indicators analyzed, and we analyzed the ones we mentioned of what had been done and recorded. And we are comparing, you see, second quarter 2019, this would be the gray line, and the first quarter 2020, which is the orange line. Important data to take into account. In the pre-surgical assessment, we see that in the second quarter of 2019, this was not done, but in the first quarter of 2020, yes, indeed, it was practiced on 57.14% of ostomized patients. And in post-surgical assessment, it took place only in 28.57% of the ostomized patients compared to 85.81% in the first quarter of 2020. And maybe the most important set of data here is that both as regards post-surgical training and follow-up and the acquisition of skills in the first quarter of 2020, we achieved 100% of those ostomized patients compared in the second quarter of 2019 to the figure of only 57.14%, the post-surgical training, follow-up only in 14.28%, and these skills were only gained by half the patients, the ostomized patients in that period, approximately. So, as a conclusion, we can say that yes, there was an improvement in all the measured indicators. Very possibly the improvement is due to an improvement in records and recording, also the implementation of the good practices guide. The only indicator where we don't see a great difference is in marking in both quarters, but that is due to the fact that marking precisely was one of the interventions that had been practiced already for a time in the studied units before the implementation of the good practices guideline. And it wasn't only done, but also recorded. Then carrying out all these activities and the improvement of all these indicators leads us to an improvement of the quality and care that we have rendered to these patients. And what about the implications for practice? Well, we have divided into two. We have, on the one hand, options for improvement, because in this study, we realized that both the training and the pre-surgical assessment has not reached the percentages we wanted to reach. So we should work more on this, go for improvement activities to see where the problem lies and try to solve it. And on the other hand, we've also seen that there is quite a problem as regards marking of the emergency patient, because the stomatotherapist nurse that typically is in charge of this marking is only to be found in the hospital in the mornings from Monday to Friday. So it would be necessary to train these general surgery nurses to carry out this marking when these specialist nurse were not there. And there are two main research lines that can start here. On the one hand, an interesting thing to take into account is to study the implication of these interventions with the complications that till later on tend to appear with these ostomized patients, whether there are more or less, or whether there is a change, and also the quality of life of the patients. So relate whether there is a reduction or an increase in quality of life of these ostomized patients after the implementation of these good practices guidelines, and see it per patient, okay, not only on the basis of complications as a number. This is, well, these are the references, the bibliography, the literature that we used. And finally, let me say goodbye with a sentence of Bertrand Russell: in all activities, it's healthy from time to time to have a question mark about those things that have been given or taken for granted for a long time. We should always think what we do and why, and we should look always for the best evidence to render the best quality of care for our patients. That's all. Thank you very much indeed.
Muchas gracias, Sandra. También gracias por ajustar.
Thank you very much, Sandra, and thank you for being very good about time. A very interesting piece of work. If you all agree, we'll leave the questions and answers for the end of all the presentations, as we did yesterday. For those of you who connected later on, let me remind you about the fact that this is a bilingual panel, and you can choose the translation into the language you'd rather have. Go to the menu bar where the world icon is, and there you can select the language you'd like, or whether you only want the original. We go on now to Paz in Spanish. You have the floor, Paz. So please share your screen. Good afternoon. I wanted to thank the organizing committee for the huge effort that they've made in organizing this conference, and thank you to the scientific committee for having accepted our work in the conference. Our work is on features and autonomy upon discharge in ostomized persons and the influence of gender roles. Well, the first person to sign and other authors state that there is no potential conflict of interest. Colorectal and bladder cancer are very prevalent both in men and women in Spain, and many of these people eventually will require surgery, and many of them will eventually end with an elimination ostomy. So when a stoma is practiced, well, great physical and psychic mental changes take place in the persons, and we see complications appearing. It's pretty frequent, and that means an added difficulty in ostomized patients. As well as what I have just mentioned, there is a change in the social work and family environments, and undoubtedly in these situations, the support of the specialized nurse and of the family is very necessary. In our hospital, the University Hospital in Valencia, the stomatherapist nurse has and follows the good clinical practices guide of Renau and for adults that have to live with an ostomy. So they take care of patients both in the pre-surgical phase, in post-surgical phase, and undoubtedly this has extraordinary benefits that improve the life of the ostomized patient and his or her family. When a person has to go through an ostomy, this is a very stressful event and it requires a certain adaptation. Lazarus in his facing model, in his tackling coping model, told us that adaptation depends on two main aspects. One, which is the personal assessment of the stress, and then also the personal, social, and cultural resources that that person has to develop two types of strategies for coping. One, a set that has to do with the problem, and others with emotional regulation. Men typically use those that have to do more with problem solving, and women tend to go towards emotional regulation to cope better. The literature describes as well the ostomized persons develop three stages. First of all, well, to adapt to this ostomized result. First of all, acceptance, then adaptation, and finally autonomy, which is the moment when the person can be in charge of him or herself and of the stoma. These three stages are part of the treble A model, and they are related with each other, and they are also interdependent. In our research, we want to, well, the intention is to describe the degree of autonomy upon discharge and any factors that are related to it, and also analyze the influence of gender roles. This is a retrospective observational study where we have a review of electronic clinical record taking place from January 15th, 2019 to February 26th, 2020. Inclusion criteria were persons over the age of 18 who have been submitted to ostomy, and exclusion criteria, well, persons with cognitive or functional mm, disabilities where the alteration in the autonomy for self-care is not conditioned by the relation of an ostomy. Variables to study, well, general variables related to surgery, specific related to the stoma, biological related to the person, social and cultural, and finally, the autonomy upon discharge. There we assess the handling of the stoma, autonomy to get dressed, and for personal grooming with three different scores. High, when the person is totally independent; moderate, when the person requires some kind of help; or low, when the person is totally dependent. This is a descriptive analysis. The statistical tests necessary were carried out for the descriptive analysis, and groups were compared with statistical significance of p less than 0.05. The study was passed by the committee of the department in Valencia, the ethics committee, in March 2020. As to biological features, we can point out that the ostomized person in our unit is usually 69 to 70 years of age, BMI of 57, hospital stay of 12 days with two comorbidities, the most frequent neoplasia and diabetes, and practically half of the patients had or had received chemotherapy. As to social and cultural traits of these people, well, we have to highlight that most of them were married. The main carer was the partner and the daughters, and they lived in an urban environment. As to the description of surgery, 60% this was programmed surgery. The main stoma carried out colostomy and then ileostomy, with 63% permanent stomas and 67% marking of the stoma. The main reason for surgery was neoplasia, and the shape of the stoma, according to the skin, was protruded, and 56% of the persons ostomized did have complications ensuing. As to the complications, the most frequent were dermatitis associated to the kind of stoma, and the most frequent is in ileostomy and in uroileostomy, and also adhesions that is related to retraction of the stoma and the non-practicing of the marking. As to autonomy upon discharge, in general terms, we should mention that there's a low degree of autonomy when the patients are discharged, and this autonomy is slightly greater regarding, well, personal grooming and getting dressed. And although it has no statistical significance, women tend to have a slighter improved autonomy compared to men at these ages. Regarding autonomy in the moment of discharge, we can say that the autonomy of the patient has a lot to do with age, with the number of days in hospital and the number of comorbidities. And there's less autonomy the longer the hospital stay was, the greater the age and the greater the number of comorbidities. As to, well, if we separate according to gender, we can see that in men, the autonomy upon hospital discharge is related to the number of comorbidities and age, and also to the fact of living in an urban environment, whereas with women, the autonomy upon discharge is more related to hospital stay and the non-carrying out of the marking of the stoma, and the autonomy for personal grooming and getting dressed in women is linked to the ASA, which is the anesthesia risk index. We can say then that the profile of an ostomized person in our unit is that of a person over 69 years of age with two comorbidities, pre-obese and dependent, well, independent for daily activities, daily life, married and living in urban environments, taken care of by the partner or daughters with a good family or friendship support, and practicing leisure activities outside the home. It's a scheduled operation with a stay in hospital of approximately 12 days, and the main surgical indication is abdominal neoplasia and complications, mostly digestive stomas, colostomy especially, and more than half come with other complications, most frequently dermatitis and adhesions. And this is data similar to what we find in the literature. As to autonomy upon discharge, well, despite the intervention of the stoma therapist nurse, this level of autonomy is still low when patients leave the hospital. In men, the low autonomy is of more than 60% dependence, and this is related with age, with the number of comorbidities, and to the fact of living in the urban outskirts. This relates well with what is described in the literature, where we read that men usually delegate care to their wives, and this social demand increases in rural areas compared to urban areas. In women, it is the contrary, really. Autonomy is related to other features that are associated to the more complex pathological processes, when there are more days of hospital stay, when there exists an absence of marking of the stoma, and also when there is a higher degree of bad diseases. Indications for practice, well, the difference of coping regarding ostomy means that low autonomy in self-care is expressed differently among men and women. And this is determined definitely by gender reasons. So we require strategies in the therapeutic accompanying, both for men and for women, that should be different, with nursing interventions that are specific. In men, we should promote self-care and also act to prevent the tiredness of the role of the carer, because in some interventions that we could think of, that we could establish, would be individual teaching to increase coping strategies, facilitate co-responsibility, and give support to the main carer's role. And in women to go for self-grooming and also helping them psychologically to cope with the new situation, having full awareness of themselves, active listening and support groups. And that's all. Thank you very much indeed. Thank you. Thank you, Paz. Okay, we're going now to the next.
No sé si está, no sé si está conectado.
Miguel Ángel Herrador Cañete. I don't know whether he's in a list of panel members. We don't see him on the screen. Right. We will therefore give the floor to the next speaker, and maybe our staff, some of the staff members will solve the technical problem. The next paper will be delivered by Diana Churi, who is not connected, because I think that she told us she would be unable, she might not be unable to get connected. So we'll give the floor to Elena Garcia. Elena, you have the floor.
¿Me habéis quitado el vídeo antes? A ver, ahora, perfecto.
There we go.
Voy a pasar a compartir la pantalla. Vale, pues nada, en primer lugar.
Well, first of all, let me thank the scientific committee for giving us the opportunity to share the results of our project and convey our congratulations for organizing such a meeting with such a different format. But everything seems to be going well. I'm one of the main researchers of this project, together with Encarna Martin, who is a geriatrician at León Hospital. The project is taking place at the health center within the framework of the San Juan de Dios Foundation, with the clinical team of Hospital at León and the technological cooperation. We found an algorithm that enabled us to identify clinical parameters that have an influence in the diagnosis of cardiac amyloidosis from the point of view of the nursing activities. Cardiac amyloidosis is a rare condition with a prevalence, an approximate prevalence of 2%, but it is estimated that 10 to 12% of those who have this condition are underdiagnosed. There is an amyloid deposit in the heart, and in this case, it involves people over 75. And in those people, 25% of the amyloid deposit is on the myocardium. There is restrictive heart disease with a poor prognosis. So helping those people will improve their quality of life and even their survival. In this case, we found AI, artificial intelligence, as a tool to improve diagnosis and identify those patients to set a treatment, because we now have drugs available for this purpose. This is the study that started by defining a number of variables. In studies with AI, we start on the basis of scientific evidence. We take the parameters that were used in clinical trials or in some follow-up studies, and these are the variables that the machines use to find patterns and identify the variables that are a part of our diagnostic algorithm. And then we have expert sessions, etc. The data collection at Hospital de León took place in people over 75. We identified both structured data and unstructured data. Unstructured data is something that is written with a free text. And the text has to do with patients going through the hospital and through the Department of Cardiology. All the regulations for data protection are complied with, safety, a process for anonymity purposes was also carried out so as to do away with any data that could identify patients, relatives, or professionals involved in each individual process. And then, as a third part, we have a search for patterns in the entire sample or for other purposes. And here I wanted to reflect the entire process from data collection to the final basis and the way everything is processed. In this specific part of the project, our goals were identifying the clinical parameters, as I said before, both in structured and non-structured data in patients with a diagnosis of heart problem through the computerized clinical record for both nursing purposes and medicine. In focus groups, we have the participation of all professionals who may be related to this kind of patients, geriatricians, cardiologists, internal medicine, pharmacists, nurses. And in fact, this hospital has been working for over 20 years with the clinical electronic clinical record, so they have an experience in terms of entering data, etc. And the individual selection was done very rigorously. In text analysis, we studied the semantic content of experts' remarks. They were asked to write about common questions in the clinical practice when caring for this kind of patients. And then we wanted to identify those patients who were underdiagnosed with cardiac amyloidosis. And we also related that to the treatment process and the ways to manage the patient. And here we see the variables that emerged in all these parts of the body, not only the heart. Those patients have problems in other functions, generally speaking. And always thinking of data that could be interesting to identify and diagnose those patients properly. So we collected data, we analyzed the data according to Browns and et al. We set up focus groups with a semi-structured script and lasting for 2 hours. We had 2 groups so as to identify terms, consider the semantic analysis, and confirm that we identified the proper terms. As to structured data, we identified the symptoms compatible with a diagnosis of heart or cardiac amyloidosis, and we classify them. Extracardiac symptoms like those that are found in the scientific evidence, and as non-structured data, which was the most important part, we identify those terms that could give us hints to find information patterns so that SOPRA engineers could find data to generate the algorithm. Conclusions: the semantic analysis of evolutionary text of nursing, basically, and other professions through those terms that we previously detected in the expert session enabled us to identify new red flags that were very important in the diagnosis of the disease. And as I told you, we have 98% specificity. Discussion and future lines for our research, the massive analysis of information coming from clinical records, nursing clinical records, may enable us to identify clinical parameters, signs and symptoms that may help make the differential diagnosis of some diseases that are difficult to diagnose, and that will encourage early detection of those diseases, thereby improving the morbidity and mortality and the quality of our patients. In fact, what we aim at is finding indicators that can be built into the structure data, and now that are getting lost. Colleagues read the data, or professionals, but they are not recorded. So some other words that were identified by the algorithm are here: diagrams, trigrams, words that belong to different settings, but the algorithm will take into account the presence of that term, the frequency, so as to be able to set up the right algorithms. This is all from me. Thank you. Thank you for your attention, and we'll be happy to answer any question you might have, or you get in touch with us. Happy to answer. Thank you. Let me now give the floor to our next speaker. I think we found Miguel Ángel Herrador Cañete, didn't we? I think he's in the room. Miguel Ángel, could you turn your microphone on, please? Hello, hello, good afternoon. Well, we would like to see your video. There you are. Are you going to be speaking English or Spanish? Yes, in English. Since we are in a bilingual session, our speaker will be speaking English, so the interpreters will now turn into the Spanish version.
Compartir pantalla con tu presentación, Miguel Ángel. En el botón de abajo, ahí, muy bien.
¿Se ve?
Sí, se ve muy bien.
Vale, ¿puedo comenzar entonces?
Sí, cuando quieras.
Muy bien. Good afternoon. My name is Miguel Herrador. I'm a nurse, of course. And with your permission, I proceed to present the following article. Before getting started, I declare that there is no conflict of interest regarding the publication of this article. The metabolic syndrome is defined as the coexistence of 3 or more cardiovascular disease risk factors, including hypertension, hyperglycemia, hypertriglyceridemia, low high-density lipoprotein cholesterol, and central obesity. It's also a lifestyle-related cardiometabolic risk that has been becoming hyperendemic around the world, being present in 80% of sedentary adults with heart disease. This situation causes an increment in coronary heart disease that produces disability and premature death, and in addition, an increment in healthcare-related costs. On the other hand, high-intensity interval training, hereafter referred to as HIIT, is defined as the physical training that consists in short periods of intense exercise with short periods of rest in between. This lifestyle intervention improves metabolic syndrome components and cardiorespiratory fitness, which lower the risk of cardiovascular disease, besides being more time efficient than moderate intensity continuous training. The main objective of this review was to assess the change in body composition and biochemical that HIIT produces in the component of metabolic syndrome. The secondary objective was to compare the effectiveness HIIT's volumes in reducing those components. Regarding the methodology used, a systematic review and meta-analysis of randomized controlled clinical trial was performed. The search used terms related to metabolic syndrome and the different modalities of exercise and training. In each search, mesh terms were used in combination with Boolean operators according to each database. Several sources, including PubMed, Medline, Embase Web of Science, Coput, or ProQuest, were searched. In order to set the eligibility criteria, Pico search strategy was used. The research was focused on participants aged 18 years of above with metabolic syndrome and undergoing intervention with at least one HIT group. The pre-specified outcomes were accessed through 3 comparisons involving HIT intervention. The studies taken into account had pre-specified eligibility criteria and were reported in a Prisma's flowchart. This review was performed using Prisma's statement for reporting systematic reviews and meta-analysis. In the data analysis, odds ratio and confidence interval were calculated for all articles with sufficient data. Heterogeneity was assessed through the computation of E-squared statistic and heterogeneity chi-squared, which measured the degree of inconsistency indicated the proportion of variability between studies. For the meta-analysis, all data were introduced in Recon 5 software to analyze the result. The analyzed group, there are 3. First one, the same group before and after HIT intervention. Secondly, a HIT group versus a control group. And the last one, a HIT group against a low volume HIT group. The study's quality assessment was determined using the consort statement for reporting trial, obtaining a mean score of 6.56 over 10. In the performance of exercise protocols, the modality was treadmill or stationary cycle. The intensity of the interval oscillates between 80 and 90% of the MHR, and the active recovery between 40 and 70% of MHR. Each interval had a duration of 4 minutes with recovery periods of 3 minutes. In the HIT groups, the median duration of exercise ranged from 38 to 45 minutes, and the low volume HITs varied from 17 to 38 minutes. Regarding the risk of bias, the fundamental weakness in the most of the researches is located in the blinding process, which is non-existent or indeterminate. Besides the blame bias, selection bias was another risk to highlight, since over 70% of the studies analyzed do not analyze detailed allocation concealment. However, the remaining risk of bias is mostly low in all article research. When body weight and body composition data is analyzed, HIT versus control groups show a significant reduction in waist circumference, where the results are consistent due to their heterogeneity. Additionally, HIT group compared with a low volume HIT group evidence a significant reduction of weight loss with acceptable result in heterogeneity and overall effects. Relating to the analysis of cardiovascular risk factors, of cardiometabolic risk factors, in the comparison of the studies was found a significant decreases in systolic blood pressure with moderate heterogeneity, and a significant overall decrease in systolic blood pressure with solid result because of the low heterogeneity as well. A similar global reduction was observed in the analysis of the same group before and after HIT intervention. In this comparison, the systolic blood pressure had the greatest reduction, but in diastolic blood pressure, the reduction was also notable. Both comparisons have reduced heterogeneity. For this reason, the result can be taken into account. The main finding in that is that HIT improves on metabolic syndrome. Therefore, HIT feebleness is not the effectiveness, but the safety during the high-intensity bouts. More randomized control trials need to be conducted before HIT can be fully adapted as a therapy. HIT is effective in reducing hypertension and abdominal circumference, but although a reduction in weight has also been observed, the overall effect was not significant, perhaps due to the muscle mass gain. For this reason, weight might not be a good indicator for the efficacy of the intervention. Short intense interval exercise have been shown to elicit training adaptation while being more time efficient. In this sense, the evidence suggests that just with one HIIT session, the benefit of HIIT would appear. This revision had several limitations. In the first place, there is no universal upset definition for HIIT. Besides, information on age, ethnicity, and socioeconomic status of participants was limited. Finally, insufficient evidence was available to determine whether a dose-response relationship exists between HIIT workload and risk factor for cardiovascular disease. However, one of the strengths of this review is the conclusion of randomized control trials. Inclusion. Besides, the sample size was larger than in similar studies, and the heterogeneity between reviews paper was from low to moderate, which strengthened the result of the study. Another strength is that most of the intervention less sufficient to assess a magnitude and sustainability of clinically meaningful. In closing, with your permission, I'm preparing to read the conclusion of this review. HIIT notably influenced the reduction of abdominal circumference and blood pressure, being able to conclude that it is an effective strategy for reducing the number of metabolic syndrome components. There is low evidence that HIIT improves specific metabolic syndrome parameters such as LDL-C, insulin resistance, or triglycerides. The difference between HIIT session volume is mainly reflected in weight loss and slightly influenced the reduction of the abdominal perimeter. There is no significant difference in the rest of the parameters related to metabolic syndrome, and it can be concluded that low-volume HIIT sessions are effective in improving metabolic syndrome levels. This result evidences how a lower volume of activity can produce improvement in the component of metabolic syndrome, which could increase adherence to training. This finding suggests that exercise guidelines for lifestyle-induced cardiometabolic disease could include HIIT. Incorporation of HIIT into an exercise-based rehabilitation for chronic diseases may be a more feasible way for people to reach a level of exercise that promote health-enhancing benefits. If participants are adequately screened and the HIIT is prescribed and supervised by qualified individuals, it should be available as a complementary approach for METS treatment. Following two slides, the reference used are shown. Thank you all for your attention.
Muchas gracias, Miguel Ángel. Vamos a pasar a la siguiente ponencia.
Thanks very much, Miguel Ángel. And now on to the next paper, Joaquín Salvador.
¿Estoy aquí?
Sí.
Here I am. I'm waiting for the permit to be hanged.
He puesto en modo presentación.
Joaquín, el vídeo lo puede iniciar ya si quiere.
Sí.
Sí.
Buenas tardes. En primer lugar,
Good afternoon. First of all, I'd like, just a second. We would very much like to see you, Joaquín. But you should do something so that we're able to see you.
de acuerdo, pues en primer lugar.
And now, there we go.
Bien.
Everything all right. Well, first of all, I'd like to thank the organizers for allowing us to present our work.
Bien, que se titula La gestión familiar de la fibrosis quística.
Family Management of Cystic Fibrosis, a systematic review, and we have no conflict of interests. This is my agenda, and cystic fibrosis. I'm having slight problems. Cystic fibrosis is a genetic chronic disease that can be found in a high number of families, and it starts as of conception itself. 90% of patients with cystic fibrosis have COPD, pancreatic failure, increase in sodium levels, and induction to sweat. In recent decades, survival of those patients has gone up, probably due to improvements in diagnosis and the management of the disease. In Europe, the difference of incidence in countries is high. Finland is the country with the highest incidence. In Spain, we have one case out of 3,500 births. Cystic fibrosis does not only involve the patient, but the implications of the disease involve the entire family, thereby leading to structural changes that may affect the family altogether. How do we care for a patient with cystic fibrosis? Well, we have to prevent the implications of the disease for the family. So the family should approach the disease by participating in the caring process, normalizing or standardizing a family as strategies to prevent consequences in the other family members. So nurses are very important in this respect because they are usually very much in touch with those patients and they can help them resort to the healthcare system. And this is the goal of our study. The question was set up. We wanted to see how families managed or approached the disease. There was a systematic review of studies that had been published that far, following the PRISMA statement, as you can see on the slide. Then we started collecting data and we set inclusion criteria in Spanish or Portuguese, with quality of life being assessed through the proper scales. Those patients where all the data could be collected were not included. In the flow diagram, you may see how we identify 603 recordings, and then after the selection process, we took the sample of the 3 studies that are the basis of, or the studies that were the basis of the studies. 6 were quantitative, sample size 14 to 167 individuals, clinimetric, very different tools, and the results were put together or that were set up around the 3 main goals. We wanted to see the implications of cystic fibrosis for patients, the specific clinical affectation, and in terms of their behavior, we were able to find 3 relevant elements: aggression, depression, and compulsivity. And more flares or exacerbations were found in families who were rather poor. There was, amongst parents, there was special involvement in when patients were admitted in hospital. Mental health went down, family activities decreased, and the working productivity went down as well because parents had to care for the sick child. In terms of siblings, since parents had to devote more time to the sick child, siblings had some kind of negative involvement because they felt less cared for. There was an increase in stress in parents, which led to an increase in symptoms of wrong behavior in teenage siblings because they perceived less social support. And if the siblings did not receive information from their parents, they didn't seem to know about the genetic features of cystic fibrosis and the possibility for them to be carriers. And that made it difficult for them to get closer to the patient, brother or sister patient. As to the family management of the disease, mothers and caregivers supported the child in terms of daily treatments, schedules, breathing, physical therapy, reminders. The parental leadership was found in the setting up of chronograms and targets and coordination tasks and improvements in the communication between parents. I'm sorry, because there's no coordination between what I say and the slides. When parents improved their communication, the supervision of children went better. The knowledge of the child's patient together with the siblings was also positive. And then there were other kinds of supports like financial resources for children to support them in assuming the responsibility of treatment, barriers to treatment. The late diagnosis of the disease made it difficult to receive family support, and the support of friends was very encouraging when they didn't have any kind of demand. In terms of normalization strategies, had to do with changes in family routines, reordering tasks and schedules, especially having to do with treatment and school. And a strong bet was done in terms of the socialization of children. Barriers, exhaustion due to the burden of care, lack of experience, the care of other members, the interruption of family plans. This made it very difficult to have everything going back to normal. And as to participation in the caring process, there was a need for continuous caring, especially in younger children. In many cases, there were therapists going to the home for breathing activities. And when the child grew, the presence of the parents in the caring process generated conflicts. Discussion. This disease involves the family structurally speaking, as well as process and emotionally speaking. Caregivers, mothers, role of gender, family care, and that might in turn lead to problems. The management or the family management of the disease was a key element, and this study has some shortcomings in terms of the number of databases, timing constraints, or publication in other languages. So we cannot make general statements about our conclusions. So let me conclude. We've seen that cystic fibrosis involves children and teenagers.
Para llevar las rutinas familiares y sobre todo mantener la escolarización o la socialización, lo que puede afectar a su comportamiento. Las familias encuentran dificultades para integrar la enfermedad en su cotidianidad, especialmente en los cuidadores familiares aparece sobrecarga y en los hermanos sanos aparece una menor disponibilidad paterna. La gestión adecuada de la enfermedad a través del apoyo, la normalización y la participación podría favorecer la integración de esta enfermedad en la familia y evitando las consecuencias no solo para el niño enfermo, sino para el resto de los miembros. Consideramos que las enfermeras son un apoyo fundamental a las familias en estas estrategias de gestión familiar de la enfermedad, en el caso de la fibrosis quística. Con eso terminamos y le agradezco el interés y la atención y quedo a disposición de cuantas preguntas o comentarios quieran hacer en su momento. Muchas gracias.
Muchas gracias, Joaquín. Esta era la última.
Thank you very much indeed, Joaquin. This was the last presentation of this panel. Thank you very much indeed to all speakers. I really think that they have put forward very interesting presentations, some of them really very much related to each other. Now I'm going to give the floor to the participants in case you might have any questions. I have with me Ana Mateo and Susana, who will help with the organization of the Q&A session right now.
Ahora habrá un break, ¿no?
I don't know whether we had questions. Yes, please. Well, for the time being, there aren't any questions, no. Well, before, yes, somebody was raising a hand on screen and we said, please to write it down in the Q&A section. So remember, if you have questions, please use the part for that in the menu bar. So it seems that nobody has any question here in our virtual room. In the meantime, yes, I would like to ask Sandra, because really I found it a very interesting presentation on the assessment of this process of the implementation of the ostomy guideline. And well, I saw that yes, that there were pretty big differences before and after. And one had to do with markings. And I saw that you had established a difference between emergency patients and scheduled surgery patients. But my question is, do you also have a subset of markings according to those emergency markings and markings for scheduled surgery? Because of course, data might differ quite a lot. Yes, we'll give you the microphone on the video, Sandra, don't worry.
Vale. Ahora. Hola, buenas.
Hi, hello. Well, regarding marking in emergency surgery, well, frankly, we don't have the specific subset, only as to marking in general. It is true that, however, I can say that, yes, there's a certain difficulty. I mean, most of these emergency patients, we can't get, because precisely they don't come along to the unit, they go straight to the operating theater. And there we don't have the specialist nurse. And that's what I indicated. I said it would be very important to also train the staff, not only for outside, but also surgery team staff, so that at least we could get to more patients. So yes, you have tackled it, right? You see that there's room for improvement to have more involved professionals in order to make sure that you could get those emergency patients in as well. Yes. Okay. Thank you. Thank you very much. Yes. Oh, sorry, Ana. Yes, please go ahead. There is a question for Joaquin Salvador about cystic fibrosis, about the family management of nurses. What techniques do the nurses use? Is it well accepted by the family? Well, maybe I didn't explain adequately in a systematic review. This family management of the diseases is carried out by the family itself. We think it's a coping strategy on behalf of the family when there's an individual who's ill, typically chronic diseases, independent patients. If the family doesn't handle that properly, then this is going to have negative repercussions on the health of the individual and the family. We have worked on it. And we took as our basis the nursing criteria of nursing results. And we know that family handling of the disease has three essential pillars: the way in which the family is giving support to the member who's ill, seeing the evolution of the disease, helping out, giving care, usually this is done through family caregivers. It's also important in the case of diseases like cystic fibrosis, in which the contact with the health system is continuous. So of course, it's very important that the family actively participates in this process, collaborating with all health professionals. And in the case of cystic fibrosis, many patients start well immediately after birth. So it's very important to get especially the parents' participation and involvement in the whole process. And there's another third pillar of the family handling that has to do with the normalization of the family. The family obviously is affected by the impact of the disease. And it doesn't only affect the nucleus of the family, but other members. And sometimes, well, because they all devote everything to that person that's poorly, and without being aware, stop taking care of the different needs of the other children, for example. So then the family has to anticipate normalization strategies, possible routine changes, making rules more flexible and roles more flexible to make sure that no member of the family suffers the consequences of the disease. We believe that this makes up what we term the family management of the disease. And we think that nurses have a lot to say and that they can really give support to the family, understanding how these families, through, well, counsel advice, can improve this support and become involved in a different way and better take care of the consequences of the disease for the person ill and for the other members of the family. So then this is what the nurses can do. And in a review on cystic fibrosis, we saw that, yes, indeed, some studies point to the importance of this and the consequences of the disease on the whole family. Thank you. Thank you, Anna. Yeah, Joaquin, related to this, I was wondering whether in your findings in the systematic review, you found something, because sometimes it's complex to measure the results of family support. So did you actually see that studies came from validated scales and scores? Because, or is it all independently scored? We didn't find validated scores or scales in the civil university. In the research unit, we use a special scale, which is the family support in times of disease. And it has been used by other groups that asked, could they please use it? But we've made it up ourselves. It's based on nursing criteria outcomes, and it has to do with family support and family welfare. And it takes 3 support criteria: 1, to the deceased member, participation of the family in healthcare, and the normalcy of all members. We think these are 3 crucial elements in order to make up a good a family management of the disease. And please don't hesitate. This has been published, and I'd be delighted to share it with you. We have it. This is what we used. Thank you. Thank you very much for this information, because it is true, it's difficult to find validated scales, especially in this context, that are validated in Spanish. So thank you for the information. Thank you. Any further question? No, no questions. Okay. Well, take advantage, because if not, we'll ask many questions. We don't want anybody to have any doubt remaining. All these, we know, are different subjects, and they might refer to different pathologies. But if you have any doubt or clarification, now's the time. I did want to ask about ostomies. I really think that your study, your research is interesting, and specifying those features and traits in order to assess the autonomy of the patient. And it means that you can really give tailor-made care. So you've measured this before discharge. And my question is, are you going to replicate the study in the different stages of the follow-up of the patients? Yes, yes, Laura. Truth be told is that, well, COVID came, didn't it? Before we could go on to develop this other part. Undoubtedly, we believe that these are the very first steps of quite a large study that we believe is going to be giving very good results. And yes, indeed, we intend to go for this good follow-up of patients. I'm the stoma therapist nurse at the hospital. I am in charge of follow-up, both in the pre-surgical stage and post-op, not only during the hospital stay, but I actually have this outpatient follow-up when patients go back home. I do this physically, but also on the phone. And well, yes, our intention indeed is to continue to gather data because we really believe it's important, but not only to analyze the autonomy of the patient, but also what is happening. And because what we do see is gender influence in the behaviors that we want to study further. Yeah, somebody has a microphone open. I'm sorry. So could they please mute the microphone? Thank you. Yes, now, good. Yes, indeed, as you were saying, yeah, I did imagine it might be for some reason, some stage of your study. Well, we eagerly await further results. It's very interesting work and you can extrapolate so much, can't you? Yes, absolutely. And this is a field that seems not to be very large because it seems something very specific. Yes, I mean, ostomies, but then you realize it happens so much. Yeah. And it affects the lives of people so deeply, so profoundly that, it affects all spheres, all environments. And yes, well, of course, the repercussions are very strong too, very intense. And we see then that the field is a marvelous field for research. Really, we can help these people a lot. Thank you. Thank you very much for this good research. Good work. No, thank you. Thank you. It's a luxury to be here. Okay, thank you for sharing this with everyone. Thanks. I don't know whether there is another question, Anna. Anna, you have your microphone off. Do we have a question? Yeah, a question from Miguel Angel. Could you explain further whether there is more than one type of HIIT? So depending on the volume, there seem to be differences.
¿Debería responder en inglés?
Yeah, I should answer what, English, Spanish? No, the question was in Spanish. Okay. Well, yeah, as I mentioned in the presentation, the concept of high intensity intervals is a concept that's not well defined. And concerning all the articles we read, we selected two main articles, one with one single session and the other with 4 sessions. So those are the two main variables that we work with in the meta-analysis. So yeah, these two variables exist. I don't know whether this answers the question. Okay. Well, we'll wait and see whether anybody mentions something about this answer. We do have another question for Paloma Rodriguez about implications for, what about the continuity of care, both in training and education of the patient and the community? Well, it's me, isn't it? Yeah, sorry. Yeah, it was Paloma, but it's you. Yes, sorry. There's the P, path, yeah. Well, the question is continuity of care in the community setting. Well, listen, at the hospital, when the patient is discharged, as regards the immediate post-op, that is the first 30 or 45 days, I carry out an intensive follow-up because I'm the specialist nurse in hospital, but all patients leave with the discharge document and then go along to the primary care health center. And these patients are shared, so to speak, both by nurses in primary care and myself. So if any complication ensues or if there's any incidents, anything that our nurse colleagues want to ask me, well, then I continue to be responsible for caring for that patient. But of course, with that special report that they take along to the primary care center, and then through communication with myself, patients, of course, have to continue follow-up at home because it's much more comfortable for the patient and for the family or environment of the patient. So we think about care continuity in this way. I don't know whether this answers the question that was posed. Very good. Well, I'm sure they'll say so if this is not the case. I'll let you know. Thank you. This seems to be it. No more questions on my side in the Q&A section. Well, I do have a question for Elena, which is, I found your study very interesting. I wanted to ask, because I understand that the acceptance of the results of this study is not very high because, well, participation is multidisciplinary of all the persons involved, and the possibility as to whether you've been successful in this identification of clinical parameters and for it to be extrapolated to the pathologies. Thank you, Laura, for the question. Yeah, of course. I mean, we think that this is a work methodology, and for us, this is the first project, but indeed, and going towards digital transformation in healthcare and using everything generated in clinical practice and in electronic histories and records. Well, this is the beginning. We can do much more. The project has been financed by the industry, and this has made it possible for us to establish a first contact. But the idea, of course, is to continue to work with this multidisciplinary team, and most especially with nursing, so that we can structure all the information that is not structured so far. So we would generate a kind of dictionary, so to say, yeah, a dictionary of all those indicators that can come and that can be used for the studies or can be directly incorporated in clinical practice. But the sample obtained for the study is all the people related with these types of patients in a small hospital, because it's a small hospital. In other projects, I mean, right now we're tackling, for example, hip fracture, and we are identifying patients and recruiting them. So that's the world of well, it's a different world, but it's always nurses that are behind, right? Thank you. I'm being told that the two previous questions, yes, have been answered satisfactorily. No further questions? No? Well then, this panel will finish earlier. I mean, we did have more presentations. It's true that finally have not taken place. And so that means that we're going to be having a longer break. Thank you very much. Thank you to all panelists for the presentations. We know that this year things have been difficult. It's been difficult to do research and, well, even difficult as well to work on dissemination. Thank you all as well to the persons attending the conference, and listen, continue, keep connected and keep enjoying the presentations at the conference. Thank you. Thank you very much. Thank you. Thank you. Goodbye. Thank you. Thank you very much.
Adiós.